Dr. Veena.
Yes. Hello. Good evening, doctors. Myself, Dr. Veena Venkatesh, working at Ajanta Pharma Limited as General Manager and taking care of Medical Services Department. On the behalf of Ajanta, I welcome each and everyone for this scientific session in this evening. Today we have a interesting session. That's role of telemedicine during COVID. This is very challenging actually for all of us. And today we have with us an eminent speaker, Dr. Tiny Nair from Kerala. Sir is Dr. Tiny Nair, but the qualification goes like MD, DM. He has certain fellowships, FACC, FRCP from Edinburgh, FICPS, FESC. He is the founder and head of Department of Cardiology, PRS Hospital, Trivandrum, Society of Hypertension. He is in the editorial board, advisory member, Hypertension Journal, Indian Heart Journal, and Elsevier Publications. He is being awarded as a Best Doctor Award at Paraga Government of Kerala and has been awarded as a Best National Award in Cardiology. Dr. Nair has several interests, special interest in the areas of hypertension, heart failure, and acute MI in young patients and antithrombotics. He has worked on several clinical trials and research studies, and he has two of his books published. CMEs and delivered so many invited lectures at the state, national, and international levels. He's been Dr. Nair is an esteemed member and office bearer at various medical and professional bodies connected to his area of expertise. He regularly contributes non-medical themed articles in the Hindu newspaper as well. With this very brief introduction, I would invite Dr. Nair for his deliberation. Sir, you can please go ahead with the session. Later on, we will take the question and answer sessions. Sir, please.
Thank you. Thank you, Dr. Veena, for that nice introduction. I think today we are in a very challenging time when we are facing the true challenge from COVID and being stuck at home. And at that point of time, probably the savior has come, the telemedicine to our rescue. So what we will try to do is in the next about 25 minutes, try to look into this new challenge of telemedicine, which is something that is not very familiar to us. And you might say, okay, in the last 2 weeks, I've heard about a couple of lectures on telemedicine. But here we would actually focus your attention on what you can practically do and the real model of how you can get into telemedicine if you are not thorough with it. Now, we know that today we are connected in a digital world, right? So we are equipped with a Wi-Fi and on one hand, everybody carries in their pocket a smartphone and we have a laptop which is connected. So the connection part is easy. So everybody today is connected with each other digitally. Now the problem is the question of telemedicine has been there for a long time. We have been talking about telemedicine for how long now? It's about 10 years now. The whole concept is that hospitals, especially in rural areas, let's say rural India, are quite far, difficult to access. So the whole concept was that telemedicine would link between the large hub hospitals where specialists are mostly seated with the small spoke hospitals in the periphery, which has far less expertise, far less equipment, and far less ability to deliver healthcare. But that is where the vast majority of Indians go. So the whole concept of telemedicine is connecting on one side large hub hospitals with every equipment, every specialist to the smaller sub-centers and to transfer our expertise. Now, this sharing of expertise and knowledge was what was telemedicine all about. But if you're thinking that is what we are trying to develop today, you are wrong. That is not the telemedicine we are talking about today. That is not the telemedicine we are talking about today. What we are talking about is this. See, this is a photograph from our hospital. It is from any Indian hospital. People crowding outside your OPD with a paper in hand to see you. And you can see the lower picture where people are standing in a queue in front of the counter to get a registration slip. This is what the Indian OPs look like, unlike the Western challenge of telemedicine, right? So today we are not talking about transferring or sharing our knowledge, our expertise to a smaller center. We are trying to see, can we avoid this? Because in COVID times, we want to have social distancing. We don't want people to crowd there, not just because they might exchange infections, viral infections, but they might also give it to others. So today we are forced to avoid such pictures that we see, and that is crowding in the hospital. Now, can telemedicine help us do that? So understand that where we are migrated, it is not where we are trying to share our expertise with where it is not available. That is there for such a long time. You do that. Nobody is objecting. But today, suddenly, why there's a trust in telemedicine is because we are trying to see, can we at least avoid a little bit of our crowd who comes to our OPD for simple purpose like follow-up or show a report where the physical examination can be avoided or doesn't turn up to be that important. So this is what we are looking at today. Patient on one side, and on the other side, you see the doctor on the screen, and we are trying to see social distancing. So is it possible that the digital doctor deliver some kind of healthcare that would go hand in hand with the standard medical practice we do? We should clearly here understand that we are not trying to supplement physical examination or doctor-patient physical checkup. That is simply not possible. But we are trying to see, can we subvert or to some extent to reduce the crowd in our OPD? In fact, this also shows how interested government of India is. There's an ICMR guideline that has come on the 25th of March. It is easily downloadable. Please download it from the net. It is given by the Board of Governors in suppression of the Medical Council of India, telemedicine practice guidelines, the new guidelines. Despite the fact that there are so many KVAs, we have actually talked to send some reports asking them to review the content and give us a better deal. But then as you would see as we go through the lecture, there's a new change in both the legal and the regulatory aspects to help doctors practice telemedicine. Now, first understand that we, right from third year, we have been taught in a medicine that is one-to-one, right? Patient, doctor. We started going to the wards, learning everything from the patient. And that is why we are comfortable seeing a patient. We listen to him, the history. Next, as you see, we physically examine him, right? And then, of course, we look at his investigation reports, we look into make a diagnosis, give a treatment, and continue to follow him up and see how he does. So these things cannot be totally supplemented by telemedicine. For example, you might ask, what about physical examination? Can a physical examination be done through telemedicine? Certainly not. You can't touch the patient. You can listen to the patient through video. You can say that through HD video, I can watch his every expression, but you can't really physically examine. So the challenge is, in today's world, in the absence of physical examination, can we take forward this technology to use it to our patients in the days of social distancing? Now, so the whole point is we are trying to migrate from a physical, what we say as brick and mortar pattern of medical practice to a virtual medical practice, at least partly. Understand that today we don't travel with a paper ticket anymore, right? It has all become virtual. We don't need to go to an insurance company. We don't need to go to a bank. That's all become virtual. That is something that maybe about 10 years back was just in the realms of fantasy, right? We would never think that we would travel without a ticket. But it has come to happen. So all idea is to try to see that can we put in as far as possible virtual medicine to reduce the number of doctor-patient interactions. Now, many people don't understand the clinical relevance. Let's say a person comes to you with a headache, right? The person comes to you with headache. So I take a detailed history. I'm looking at clues. The person says, I have got a thunderclap headache. Oh, I am thinking, can it be subarachnoid hemorrhage? He says, okay, I have a headache for the last so many years. It increases when I take bananas, chocolates. Oh, can it be migraine? It is hemicranial. He says that I have a tenderness on the right side of my head. When I touch there, when it comes, I see some visual blurring. I would next ask, how is the ESR? Can it be an or arthritis, right? Uh, Next things that come to our mind, can it be an early CVA? Can it be a cerebral tumor? So many possibilities from history. Okay, then we go for a physical finding. Let us say I'm an astute physician. I find out that there's some neurological deficit of the examination. And let us say somebody else examines the patient and doesn't find a finding, doesn't get a finding. No. So the neurology, the physical examination is yes by me and no by somebody else. Or the patient has signs, yes or no. Okay, then let me ask you, what would you do next? In 90% cases of a chronic headache, which is not going away with simple painkillers, all of us would go for a neuroimaging. So we would go for a CT and MRI. Now, in a day where you can't do a physical finding, if you still get an imaging done for this patient, if you advise over telemedicine that yes, I think you need an imaging, he goes to a nearby imaging center, gets a CT or an MRI done, and sends you the scan. Can't you make a proper diagnosis in many cases? Yes, and that is what we are trying to say. Not that avoid physical examination, but in a period when you are not able to do justice to your patient by physical examination, can that be supplanted and supplemented by virtual consultation? Take, for example, a patient of hypertension on follow-up. You have been seeing this patient, you have prescribed telmisartan 40 milligram, right? And you want him to come back after 2 weeks. He has no symptoms you already have seen. He has no urine albumin. His ECG is normal. Everything is fine. And his locally blood pressure measurement is 160 over 100. Okay, so what would you do? You would add up some other drugs. Let's say we had amlodipine 5 milligram. So in this algorithm, why do you want to see him? Why do you want to get him into a place like hospital crowd where he has a higher chance of getting a COVID infection? So we can do this over the virtual network by telemedicine, and that is what we are looking at. We are never trying to tell you that this supplements physical examination. It doesn't. But in certain selected cases, you can actually avoid physical contact and still practice and transact modern medicine. So that brings us to the transaction types. The first transaction is between a patient and a doctor, and that is what we are talking about today. The patient sees the doctor and transacts telemedicine. But understand that if you go to the article by ICMR, the guidelines, you see that it can also be between doctor and doctor, a senior doctor talking about a case to a junior doctor, or a senior doctor giving a lecture about telemedicine on a topic, teaching junior doctors, or it may be between a doctor and a caregiver. You can teach a nurse or a younger caregiver, or teach as to how further care can be given. Or the caregiver can give the patient details and you can tell as to how to proceed forward. So patient doctor is what we are discussing today. The types of interaction can be synchronous, and that is what we all want, right? That means one-to-one, where it can be audio. The patient is on the telephone and says, sir, you had seen me before, now I'm feeling better, should I continue the same medicine? Synchronous, but audio. You can have synchronous and video. One-to-one, you can see the patient, so how are you feeling? He said, I have a little pain. So you can feel that the person is not well. Or he says, oh, I'm fine. You can actually see his expression like you would see in your OPD. And then would be chat or text messages where he says over the chat box that I feel fine. My hemoglobin is 13. My blood pressure is 150 or 90. So they are all synchronous. You answer immediately. And the other one is asynchronous, where he sends you a message, I am feeling fine. At the end of the day or next day, you go to the chat box and answer telling that continue same. That is asynchronous. So synchronous, audio, video, chat, and asynchronous. One of the must that the ICMR guidelines very clearly says is two things. One, the patient ID has to be clearly identified. There cannot be an anonymous medical consultation in telemedicine in India. The patient has to very clearly identify who he is, whether by his hospital number, previous registration, age, address, whatever you use. So you have to make sure that Mr. A, whom you're advising over the telemedicine, is actually Mr. A. And similarly, the doctor has to identify himself very clearly with a registration number. The whole guideline talks about the doctors are registered medical practitioner, RMP. To be registered as an RMP, you need your doctor ID, your name, and your registration number. This is basically to prevent a non-registered person practicing medicine, maybe a quack, who is trying to give some non-medical advice and say you do this and do that and create problem, right? So the doctor has to identify himself with his registration number and get into the forum, and patient has to have an ID so that tomorrow, if there's any legal issue, one can go back very clearly to what has been transacted. Now, if we look into the regulatory point, there are multiple flow charts in that big, so many page full of guideline, but don't be confused. The regulatory points are just very limited. Number one, is it an emergency situation? Okay, if it is an emergency situation, teleconsultation today in India is not allowed. You're allowed to advise him regarding a first aid and rush to the nearest hospital or a clinic. Okay, you can always tell him, oh, you have chest pain. Okay, right. So you are a cardiac patient. Do you have nitrate at home? You can say sublingual nitrate, isosorbide dinitrate. You put it under the tongue and rush to the hospital. Or you can say, oh, right, you are bleeding or you have a trauma. The nearest center to you is this, you go there. I am calling up the ER doctor and telling him that you are coming. Such advice can be given. And in a situation where you can assess the patient has absolutely no way to travel to a hospital, maybe you can give some basic advices. So basically, first rule out is in an emergency. And the first response of the doctor should be emergency, no telemedicine. Just an advice, please go to the nearest hospital possible. So today, most of the bundles that you receive as telemedicine, but first ask the patient, is it an emergency? If it is an emergency, there is no teleconsultation, you have to go to the hospital ER. Second, the doctor should assess that is this case appropriate for a telemedicine. If you think that the patient is sick or the problem is too complex to be handled by telemedicine, this is not a situation where you need to practice telemedicine. So after emergency, think that is this an appropriate case for telemedicine. Most complicated patient issues cannot be treated by telemedicine. Third is, of course, is it an audio call or a video call? There are some differences whereby audio calls have some restrictions, and it is always preferred that you have a video one-to-one interaction. And of course, then comes the very important thing, is it a first consultation or a subsequent consultation? ICMR guidelines, the regulatory guidelines very clearly says first consultation is when you see the patient for the first time, right? The first consultation is always preferred to be not in telemedicine, but as a one-to-one person, right? And if the patient has not consulted you for the last 6 months, your old patient, it is still considered a first consultation. So first consultation is a new patient or a patient whom you have not seen for the last 6 months. That is the first consultation. And first consultation, you have some restrictions, and they are: number one, you can write some O drugs. We'll come to it later in detail. But the O drugs are very ordinary drugs. They are like paracetamols for headache, some cough lozenges, and some soothings and cough syrups. So very elementary medications that is available over the counter in most metros. So these are medicines that he doesn't need actually a prescription. You can just go and buy. He's just asking you advice. He has a cough, he takes a cough lozenge. There's fever, you say you take paracetamol for 2 days and see does it look like a problematic fever and all that. Second is medicines of group A. Medicines of group A, again, mostly are local ointments. So he shows you that I have a problem in the skin. You say, oh yeah, this looks like an insect bite. You put this ointment, that is allowed. If he says that he has some local problem in the eye, you can see that the eye is inflamed, can give some anti-inflammatory for the eye. If you want to give him some local drops, maybe ear drops for a pain in the ear, or wax or anti-inflammatory drops, or you can prescribe that. So local ointments and local applicants. You can also give medications, but provided they are medications on follow-up. So you can adjust the dose of medication, but to adjust, you need to have him on the follow-up. And that brings us to the patients who are coming for review. In fact, by today's guidelines, the major scope that you have for teleconference, telemedicine transaction is patients who are coming for second consultation or review. So these may be patients who have got hypertension, who have diabetes, COPD, and they might ask you, can I continue the same medicine? So the medicine dosage alteration you can easily do over telemedicine. Can you add a medicine? Yes, you can, provided he has seen you for the same indication. A hypertensive patient, for example, if he is on, let us say, a calcium antagonist, he says, I am taking amlodipine, and you can say, okay, you can add up a telmisartan. So a different group of medicine for the same disease that he has come to you before. Or he says, I am taking metformin for diabetes, my sugar is high, HbA1c is high. You can say, okay, I can prescribe you an SGLT inhibitor. That is allowed. That is allowed. So a same disease, additional medicine is allowed, and that they are put under the list of B. So we repeat again, O is over-the-counter medications. So basically you just advise him. A are medications which are local applicants and they're absolutely safe, and probably if you are consulting him the second time, you can continue alter the dosage of antihypertensives, anti-diabetics. And for review patients, you can always prescribe newer drugs for the same problem for which you had seen. If the patient comes to you even within 6 months with a new problem, it becomes a first consult. So I repeat, that is important. So a diabetic now comes and says that yesterday I checked my blood pressure locally by a doctor. It is 160 or 110. He has a new problem of hypertension. You have never seen him with hypertension. This for you becomes a first consultation. And only the first consultant will apply. And as of now, you cannot start him on a new antihypertensive simply because he says that I have a hypertension. So today we are looking at mostly patients whom we have seen before, and you're trying to see whether you can reduce the crowd in the OPD by asking them to come back. This is how Government of India, the guidelines are put in. List O is, you can see, for as video, audio, any teleconsultation, nature of consultation, first or follow-up, any, and list O. They are basically just over-the-counter medicines. Even without consulting you, they can always go and buy them and eat them. A list is only by video consultation, not by audio at all, and they are on first consultation mostly, which constitutes of local ointments, local drops like eye drops and ear drops, and of course, some medications of chronic disease like hypertension, which he has already been taking and they are on follow-up. That's why you see lower part of the column says follow-up. Group B medicines are a disease for which you have seen him before, and now he comes with the same disease, which is accelerated. You can add up a different medicine, but it should be for the same problem for which you had seen him before. So addition of a new diabetic medicine, addition of a new hypertensive medicine, but not a new disease at all. Everything else you can see it is prohibited, but it's Schedule X drugs or narcotics, psychotics, antipsychotics, everything are on the prohibited list as of now. We have given an application and we have sought advice from the guideline committee that can we have a relaxation and may have more medicines on board, at least for limited some responsible physicians or some guidelines so that we can prescribe them. So you can see this, the details of list O, where you have antipyretics, you have anti-cough, you have got syrups, vitamins, and all that. You in the list A, you have ointments, local ointments and drops. You also have follow-up medications for illness for refill, but they are follow-up, which means you have seen them before. And of course, list B, where you can add up a medicine. As you can see there, they are very clearly mentioned addition of sitagliptin to metformin. So add up of a medicine of the same for the same disease that you have already diagnosed. First consultation, you can also give general advice, right? So how best we can still remain within the realms of the guidelines and practice teleconsultation. General advice. You can say, okay, food, this you can do, that you can do, reduce your weight, don't smoke, advice and all that. They're great, yeah. Direction for investigation. What type of investigation should I do next time? You do a blood count, you do an LFT, you can do an RFT, you can do a thyroid function, do check up a TSH, all this you can tell him. You can advise him regarding the investigation that he need to do next time before he sees you. You can give opinion on scans. A person says that I just want an opinion for the scan, he transmits you the scans. If you're confident about the images and you say, okay, this is a normal scan, you're not giving an opinion regarding his disease. But you can give an opinion for his scans if you're eligible to do that according to your training. And of course, you can always give a second opinion. A patient who has every data available comes on the net and says that I have my angiogram, my echo, my everything. And one doctor has told me that I should go for a bypass surgery. Do you think I should go for bypass or angioplasty? You can always tell him that my advice would be that you still continue on angioplasty, or you can continue on medical therapy. So second opinion, provided the person presents you with every kind of investigation. So I repeat, first consultation would be general advice, directions for investigation, opinions on scans, and a second opinion to a first specialist who has seen the patient, and the patient provides you with sufficient amount of investigations that you need to, and you are confident that you are just giving a second opinion. Subsequent follow-up or follow-up consultation, you have a far more area where you can play. You can write general medications. You can write specific medications, like we said. You can change dosage and add up addition of other drugs for the same disease. Diabetic, you are adding up something. Hypertensive, you are adding up something. Now, with all that, you would say that, okay, I'm still not very comfortable that physical examination is not available. Is there something that we are looking in the future, not in this telemedicine guideline, that is going to come, that in the next couple of years' time would supplement my physical examination? Yes, for sure. And that is why you have the wearable sensors. The wearable sensors is coming in a big way. Whenever we talk about a wearable sensor, most doctors think about finger pickup, which will show you a heart rate and an SpO2, right? Oxygen saturation. You can also have something which gives you a continuous glucose monitoring. We have today home blood pressure monitors, which the patient can, the cuffs are so designed today that you need not put it on the arrow mark. Whichever way you wear it, they are pre-shaped and they remain in place. You just need to put it on your arm and connect it to the hardware. It will go up and go down and show you the blood pressure. So your blood pressure, your SpO2, and so many of the information. But in the next few years, what you are going to see is sensors of huge kind, from breathing sensors to heart rate sensors to calf muscle sensors to ground reaction force sensors, and sensors, huge number of sensors. You are going to have lactic acid sensors, you are going to have interleukin sensors from the sweat, you are going to have a huge number of sensors that give you a lot of data. And where will the data go? Understand that today in your hand, you're holding a smartphone, which is far more powerful than the desktop computer 5 years back used to sit on your desk, occupying so much of a space, right? And what are we doing about it? And your smartphone today is not just equipped with Bluetooth, with cameras, with microphone, with ambient temperature. It's a huge amount of input data. Okay, you can have a GPS, you have a touch screen, you have fingerprint sensor. It can, for example, if a patient's voice over about maybe few months' time is breaking, it is your smartphone that is likely to pick up first that the voice is breaking. Is he suffering from early Parkinson's disease? Okay, suppose my typing speed in my cell phone as I type is slowly deteriorating. My cell phone might be the first to tell me that maybe you have a neurologic problem. Go and see your doctor, right? If there's a tremor in my hand as I hold the cell phone, it is the first that is going to pick up even before the spouse or the kids know that there's a problem. So cell phone has a huge amount of ability to capture this data. And today with the artificial intelligence, we can easily process them and get a meaningful output to diagnose a disease. Now, we will quickly go through what most, you have a lot of bundles softwares now available. For example, you have app download. The patient, what he does is he downloads an app. There are very many companies offering this service, and then you register either with a valid government ID or whatever you have to say. You have to prove that who you are, and then you have to choose a doctor. And then you have to go to an appointment list. This is what the patient does in his cell phone, or books a time slot. Okay, and he will given a time slot for you to appear. He makes a payment, and the receipt confirmation he receives, and that payment gateway takes him just like any other bank payment. He pays through his card or whatever, or Google Pay, and that goes to your bank account. And after that, he gets a instruction downloadable that he can how to do it and the essentials of telemedicine. This is simply because he has a limited time, right? He may be given a 15-minute time slot, a 10-minute time slot, and many people may not be digitally tech savvy to use that sufficiently. So they haven't printed out how to do it and how, if they're not very familiar. Couple of sessions later, they're likely to get familiar. So this is how an average appointment scheme for telemedicine looks like, where people would say select a date and the doctor's telemedicine times pops up, he selects a time and done. So that jumps on to your screen and shows that one patient has booked an appointment at this point of time. See, all these years, the telemedicine that we are used to is some patient calls, you don't take the call, and later on you call him back and say, hey, you called, you say, okay, what, okay, medicine you increase. That is not telemedicine, right? Simply because this was an unofficial transaction of medical information between the patient and the doctor. But here, he has paid, he has booked an appointment, paying your consultation fees, and he has come on that time. So you should be available in front of your laptop or your smartphone at that point of time to give him the consultation, right? By the way, the guidelines have clearly said your fees should be at par with your standard consultation. So if your consultation fees is 250 rupees or 500 rupees, when you see a patient, you can keep that same fee for teleconsultation. Same fee, not more. You can provide it for less, but not more than that. Now, once you have the date and the time selected, you're done, then the appointment is fixed up. And then the patient is reminded in that morning, suppose he books an appointment for 3 days later, on that morning by text or mail that you have an appointment at this point of time with the doctor. He has an option of uploading investigations and lab reports. Either he can scan it or he can feed it up. Because if he goes on reading in that 15 minutes, hemoglobin TC, obviously time is going to be wasted. So he can upload either by scanning or by feeding the box. And then 15 minutes before his appointment, he needs to go to the site, either in his app or the laptop, and enter a virtual waiting room where he'll be asked to wait. This is because if the patient doesn't turn up, the doctor need not wait for the patient to come. And then the rule says that if the telemedicine was initiated by the patient, his consent is implicit, which means he need not sign a consent, but he implicitly says that he has understood all the nonsense of telemedicine has come to you, right? All the problems and all the troubles and do's and don'ts. But it is always better to sign a disclaimer. Most of these websites offer you a disclaimer, whereby you have one telling that I am not suffering from an acute disease. Second, I understand the pitfalls and problems of telemedicine. Number 3 is that I will not hold the doctor responsible for any kind of drug reaction or anything that can happen to anybody. So these are better to have a disclaimer done, and then he starts the audio and video. On the top, there should be most of them provide you with one countdown clock so that you and the patient knows that how much of time is left. And when there is a minute or 2 minutes left, you get a physical warning. From the doctor's point of view, you and me, we open the app, and if not available for teleconsultation, see, this is important. All doctors are busy. It is possible that I have given a patient an appointment for 10:30 for a teleconsultation. At 10 o'clock, I got a call that there's a patient with an acute MI in the cath lab. Okay, so I run to the cath lab. So then all this telemedicine forums, the softwares offer you a button whereby you can reschedule your appointment. And that reschedule gives you a time. I can say, okay, it's a simple acute MI angioplasty. I will reschedule by 60 minutes. So that every appointment gets delayed by 60 minutes to the patient's cell phone. And the patient always can have, no, I don't have time, I cancel today's appointment and get back his money. Or he can say, okay, I'm ready to wait. Or he can say, I cancel today's appointment, I would want an appointment tomorrow. That is his choice. But unlike the usual brick and mortar pattern, you can always reschedule your appointment and tell the patient that for some reason the doctor is not available. Now you can click to confirm or click to reschedule to go to that appointment, and the appointment automatically shifts on by 30 minutes or 1 hour to the next scheduled appointment, provided the patient accepts it, and the patient gets an auto text back telling that his appointment has been rescheduled. He can time change info, he can option of rebooking, refund, or say that I don't want consultation. Waiting room in the panel tells the doctor the number of waiting patients, and that is important. For example, and then the consultation starts, the audio video, you transact your business, you make a diagnosis, and the countdown clock continues to show the timing. It again warns the doctor that and the patient that only a couple of minutes are less. And the whole transaction, all these providers give a benefit that they record it for transcript. So if you go through the guidelines, two things are clear. One, if the entire transaction has to be recorded. Tomorrow, a court can always ask that, doctor, I want your transaction of what you told in the telemedicine to this patient. And the entire transaction recording needs to be recorded and given to the court, right? So obviously you cannot have a huge server at your home with gigabytes of memory looking into all that. The moment you register with a telemedicine provider, the provider consents that he will keep a track and a recording of all the transactions, right? And not just that, you have to make sure you also go into to the provider and sign and consent that they will keep all the data safe. So the guideline purely says it is the onus on the doctor to keep all the patient's privacy data safe, so that an insurance company should not know whether patient A or patient B is diabetic, hypertensive, what disease he has. Health data is very personal, and unless I give my consent to you as a patient to release my health data, you can't do that, and that is criminal. So you are always responsible for safekeeping of the data. You can't say my laptop was stolen and I have lost the data. The court clearly says that it is the onus on the doctor to make sure that the data is safe. This is how an average service provider's data looks like. In the center, just like the Zoom you're watching here, you have in the center Mr. Patient. You have the reverse clock running there, telling that another 9 minutes and few seconds are left. On the left, you have waiting room icon that tells you how many patients are waiting, right? You would know 5 patients are waiting or 1 patient is waiting in the virtual waiting room, right? So they have entered the waiting room, told that they have an appointment and they're waiting for you. Okay, so you have an access on how many patients waiting, and when you are talking about with the patient, you can see him, how much of time is left. Now, after you have finished your transaction, your electronic prescription, the format of the prescription is very clearly given by the ICMR guideline. You should download it and keep it with you. Electronic prescription letterhead are given. Now, most service providers also provide this, so that once it is done, you prescribe medicines, the patient can get the prescription, you can digitally sign it and then transmit it. The patient can either keep it in his cell phone or get it printed by the patient. Many of these telehealth providers also ask the patient that, do you want to buy the drugs from us? And they might actually, since they have the prescription by the doctor, they have no legal problem in supplying it, they will supply it to you. If you say, no, I'll go to the local vendor and buy, the patient can do that. Now, if you're wondering that is telemedicine is something that is going to be restricted to just pass on COVID, you are wrong. You are wrong. Today, like we talked about sensors, today everything is becoming virtual. For example, have you ever thought that the stethoscope can become virtual? Unconnected, Bluetooth-enabled stethoscope is right there available. You can see the picture there. That's a ThinkLab stethoscope, doesn't have a wire. Okay, right. So that can be provided with any health kiosk. Imagine that in course of time, years later, you'll have small health kiosks like you have your ATM rooms. A patient walks into there, he doesn't need to go kilometers away to the hospital and wait for an OP ticket or a token. He sits in front of a screen. You can see him, talk to him, and then you say, okay, I want to listen to your heart. He takes that virtual stethoscope. It is there. It is there in that booth. It is sterilized. He just takes, the system says, put it in point 1. He puts it there, right? And then he's okay, put it in point 2. Yeah. And then you can, no, I'm not very sure. Can you put back to point 1 again? The diagram shows where to put, he puts that again. And then you make a diagnosis. So with the sensors and with the virtual tools available, we are not trying to subvert a physical examination. We are not trying to bypass a physical examination. We are trying to see that by avoiding the trouble of coming to the hospital, by maintaining social distancing, by reducing the crowd in the hospital, and by giving you a better option of avoiding those troubles, can we practice medicine with the same standard that we try to provide to you today? And that is the main challenge. So finally, where are we? At the end of all this, telemedicine, yes, is the need for the future for multiple things that we have talked to you. We need a strong, dependable, easy to use application. And I see that over time. Okay, today you see your cell phone is so simple that everybody can use it. Okay, you don't need any education to use a smartphone, right? A person who can't even read ABCD can use. Toddlers are using smartphones because they are icon based. So strong, dependable, and easy to use application is what we are looking at. The medical, the service providers of most of them provide that. Their services should be upgradable. There should be absolute good level of data protection. So before you sign up with a service provider, check two things. One, how strong is that data protection? And is everything being recorded? And will they supply that record to you in case you have a legal problem? Data archive for legal protection is a must. Now, government and regulatory approval, yes, if you should read the 25th supplement of ICMR, the drug O, A, B, and what you can and what you cannot prescribe. So even the present regulatory approvals with whatever relaxation has been given still looks quite suffocating, right? So you have a little more freedom of seeing old patients. A patient whom you have seen before comes back. You can alter their medication dose for the same disease. You can add other medicines, give them general advice, see a patient scan, give a second opinion. But when a patient comes for the first time in telemedicine, both of our hands are tied, probably because the governors of ICMR also doesn't want to take a risk. Because if they relax it, there might be a lot of untoward problems that can happen. A person who says that I've got dyspepsia, a doctor might prescribe an antacid or an PPI, and it might turn out to be a myocardial ischemia, right? Somebody might complain of severe back pain. It might turn out to be a dissection of aorta. Okay, so many of the major disease might be missed out because we can't physically examine the patient. And that is why the guidelines say that probably at the moment, it is good for patients who are returning back to you. You are absolutely sure the disease they are suffering from. Hypertensive, yes, what is your BP? Yeah, I know that your creatinine is normal. I have checked your fundus, it is normal. Your ECG is normal. You can add up this medicine. Right. You are a diabetic. I know everything is normal. You can add this up. Or I know you are a diabetic, you're a little elevated creatine. You can still add up this medicine because I know that it does not alter your GFR. So for a follow-up patient, we are far more convenient in prescribing things. And I think over time, we need involvement of all stakeholders to make telemedicine the way we should practice. So thank you for your time and attention. If there are any questions, you can ask that. Dr. Veena is here. She would listen to the questions and forward it to me, and we will try our best to answer.
Yes, sir. Sure, sir. I would like to compliment for the excellent talk. You explained very well, taking into consideration of the guidelines and the regulatory requirements. But the slides were very simple to follow. So it was very nice listening to you, sir. Yes, we do have a couple of questions. Some are related to COVID and some are related to telemedicine, sir. So Dr. Jagdish wants to know, before starting HQ as a prophylaxis, nowadays this is on, what are the prerequisites needed? Because you said that it has acts on the QT interval and it SOSAR, and what are the prerequisites?
Can you repeat that? You are not audible. Can you repeat that?
Before starting hydroxychloroquine, sir,
See,
what are the
point is that
prerequisites?
we are not advising, let us be very clear on that. We are not advising starting hydroxychloroquine for COVID prevention anymore. The data on which our belief that hydroxychloroquine does good was built up is now shaken. So, 2 days back, we were talking to all the experts, all India, who actually treat COVID. I'm not an expert in that, but they have all recommended that they are not using hydroxychloroquine as a preventive measure for any COVID prevention, right? That should be very clear. That is one reason for that is one, the efficacy is not proven. And secondly, what you said is right, that this is not an absolutely safe drug. People have been telling us that I've been using hydroxychloroquine for malaria for a long time. I've been using for so many patients of rheumatoid arthritis for hydroxychloroquine. What is the great problem? But you never know when these patients had a ventricular tachycardia or a polymorphic VT at home. So this medicine tends to prolong QT. The guideline is that at least you should have one baseline ECG done, and 1 week later, if you're repeating the dose of 400 milligrams, let's say, you should have another ECG done. And if the ECG shows a further prolongation of QT, hopefully that the first ECG showed a normal QT, if the prolonged QT are not prescribing. If the ECG is further showing a prolongation of QT by 40 milliseconds, I repeat, 40 milliseconds further, we should not give the next dose of hydroxychloroquine. 360 to 440 milliseconds or 0.36 to 0.44 is the normal QT interval in the ECG. If it prolongs by 40 milliseconds further, we should not give, it is not safe to give the next dose of hydroxychloroquine.
Sir, second question is from Dr. Jagdish. Whether ACE inhibitors can be continued during COVID pandemic in cardiac
Yeah,
patients?
yeah, I
Because there
think
were some issues with some literatures
yeah.
came.
I'll elaborate for 20 seconds on that because we know that the virus, the coronavirus gets attached to the respiratory epithelium by the ACE2 receptor. So it was always thought if the ACE2 receptor is attaching to the virus, anything that increases ACE2 might be bad. And we know that when we use an ARB or an ACE inhibitor, the ACE2 pathway gets aggravated. So we thought that will it do any harm? Today, we know that it doesn't do any harm. That was theoretical, it doesn't do any harm. In fact, you should continue your ACE ARB for the patient who is well controlled. Starting new ACE in RB is also not a problem. If you have a patient who is suffering from COVID also, there is no clear indication unless there's an hypotension to stop or reduce dose of ACE or ARB. In fact, there is some data that has come out of a meta-analysis that ACE ARB may be actually a little beneficial in patients who develop COVID because ACE2, the circulating ACE2, we're not talking about the receptor, the circulating ACE2 provides some protection against the patient turning bad or getting into a cytokine storm.
There is one more question, sir, from Rajiv Lochan.
Yeah.
With rural area patients, how
Yeah.
can one connect easily and provide treatment, especially if the patients have cardiac, they are cardiac, and as they require a lot of parameters and investigations which are not available over there. Is it possible to do the telemedicine in such cases?
It is difficult. I understand it is difficult. It's a big challenge, but that is how telemedicine actually started. So, in a rural center today, there is hardly a rural center which doesn't have an ECG, right? Doesn't have any. Everybody has an ECG, and many of these centers also today have facility to check troponin. Okay, let us say there is no troponin, no lab, and the ECG machine is there. The ECG machine is so cheap that every hospital keeps an ECG machine. The problem is there are very few people available who can actually confidently read an ECG. So let's say a patient comes with a chest pain to a small rural center. He uploads the ECG simple by taking a photograph in a WhatsApp. Everybody has a WhatsApp. And I sitting in this city, look at the WhatsApp ECG and say that this ECG shows some minor ST elevation 2, 3 AVF inferior MI may be there, send the patient down. So obviously the cardiac patient cannot be treated there, but this patient gets a timely advice that they can rush through and come there. In contrast, if I see there's a 28-year-old man, no risk factors, absolutely normal ECG, and the doctor tells me that is a prickling kind of pain on the right side of his chest, I can say this is not like a cardiac pain. You can go and sleep comfortably, and when possible later on come for a checkup. So we can actually triage them depending on the disease by looking into telemedicine. It is not possible that we transact every form of treatment that is available in a large corporate hospital, that to a small hospital in the periphery. But if the peripheral hospital is manned by a caregiver or a doctor, we can always transact with the doctor and set or share our expertise in translating the reports and giving a better advice. That is all the rural urban telemedicine is all about.
Sir, a question from Dr. Girish Rao. Can't we do telemedicine to abroad patients?
Uh, I think right at the moment there is no guideline about patients abroad. But probably if they are consulting you here, the law of the land in India would hold good. But there are a lot of challenges. If the patient is a foreigner, for example, you won't be able to buy medicines by our prescription because you are not registered in the medical system. In contrast, if it is a patient who has been your patient, see, let me tell you, because this is a problem that we face so often. A lot of Keralites are in the Gulf. So a lot of them do telemedicine where they tell us that how they are. You can always give them advice. You can always give them, okay, continue same anti-hypertensive medicines or diabetic medicine, follow whatever we have just now said that you can do. And when somebody else travels back, they carry the medicine with your prescription here. But if you're talking about a person who is not an Indian national, foreigner, and he wants to consult you, there is a technical hitch.
Sir, one more question from Anish. If we look into the telemedicine guidelines, there is some confusion with respect to anti-diabetic drugs and anti-hypertension drugs. For example, is these anti-diabetic drugs and anti-hypertensive drugs, they are in list A or list B?
No, no, see, the list A and list B is just made for convenience of the doctor. I will tell you, in the A list, anti-hypertensive and anti-diabetic are there. A patient who is taking anti-diabetic and anti-hypertensive, you can alter their dosage. Okay. But list A does not talk about adding new drugs. List B gives you a more freedom, which is totally in the arena of a follow-up visit. List B gives you an ability to add up new drugs for this same disease. So let us say a patient whom you had seen before. See, if you look at the bottom part of the list A, it still says follow-up visit for patients of chronic disease. So a patient who had seen you before, he comes to you and says that, is it okay that I continue this medicine? Can I increase the dose, decrease the dose? You can do that, right? That is as per the list A. And the list B gives you a freedom of adding another medicine in the follow-up patient of the same disease but different group. Like they said that you can add, the example they've used is atenolol, you can add hydrochlorothiazide, metformin, you can add SGLT2 inhibitors. The list is artificially made to create an impression in our mind very clearly as to how far you can go in the first consult as in the follow-up. So what you said is right. The bottom part of the list A and the list B kind of overlaps, but both of them are eligible only for follow-up patients.
Sir, you mentioned in your talk that all the medical records to be archived, it is and the responsibility of the doctors. But
Yeah.
how long? Is there any guidelines suggested? How long do you have to archive these records?
No, normal archival for the hospitals are for 7 years for the legal purpose. I'm not very sure as to how long I presume it should be the same for uh, telemedicine also. If there is no court order in the probably 7 years time, that then the records might be destroyed. But today in the electronic world, there is no need to destroy records. See, they are all, there is no space constraint, right?
Cloud.
You can store huge amount of data in not just terabytes but much beyond. So it is not an issue of storage. Storage issue is not there anymore like a paper storage. But I presume after 7 years they may not be legally important.
Sir, with the patients who have probably suffered from COVID and recovered and all, even the healthcare professionals, they do often suffer from post-traumatic stress disorder.
Yeah.
Like they do require some counseling by the psychiatrist.
Yeah.
Can they go for the telemedicine option to get the advice, or because the antipsychotic drugs they should not be used as it's mentioned in the guidelines?
True. I think this is very important because see, one area where telemedicine is good is transaction of advice, right? Now, I can, for example, I can talk to Dr. Veena, Dr. Veena can talk to me, I can advise Dr. Veena, she can advise me on many things, which are general advice. Okay, they can only improve our health, they are not harmful. You can always advise a person about how much exercise to do. You can also tell him as to how to avoid smoking, how to control his diet, and how to be stress free and all that. That's all good as long as you are not talking about something totally unorthodox and like you might be knowing about the case where some doctor advised a patient of colitis that he can smoke, so that because we know that nicotine actually symptomatically gives relief to colitis, and then the person who talked about it lost his license to practice. So you should not say anything that is wrong medically or ethically. But as long as you do that, one area in telemedicine is where you can transact advice. Okay, as long as you don't prescribe antipsychotic drugs and scheduled drugs, and you give an advice to a patient of post-traumatic disorder, PTSD, or whatever, I think it is a very good forum. it is almost like not that just because it is two people, both of the doctor and the patient can be in total privacy. When he comes to visit you in your clinic, there is your nurse standing there, your junior residents are there, there's so many people around there. He may not feel very comfortable coming out with his personal details in front of the other staff present there, right? And most of our Indian OPDs are not very patient friendly in terms of privacy. So, but this is something where I'm doing it from right from my library, and you can probably do it from your bedroom. So the patient and doctor has far more intimacy in transacting their business in telemedicine. Yes, the privacy component is there. I think for advice and suggestions, this is one of the best forums.
Sir, on similar lines, a question from Suresh Kannan. In case of video consultation, how do we maintain the privacy of the patients?
Yeah, see the person who offers you the telemedicine vendor, he offers you privacy, right? Because the patient might be showing you on video things that you want to show. You might show you a lesion or whatever it is. So the vendor, when you go to the vendor and sign up a contract, he very clearly says certain things that this will be kept in absolute privacy. Second thing, and also, see, who knows that this, I'm not recording this whole thing in a video camera sitting behind me, right? Me and Dr. Veena. Or how do we know that all these attendees in Zoom is not recording it for some purpose? And tomorrow they might be putting it with a malified intention in the web. So it is the only onus of the doctor that he has to keep all the video consultations to himself. And this picture should never ever be transmitted on social media or for any reference without explicit consent by the patient. That is very, very important.
So one more question from Anish. A patient of diabetes who is on anti-diabetic drug, he requires a change of the OAD, anti-diabetic drug. So is it possible over the phone, or it's mandatory to do the video consult in this for a follow-up?
No, all that is group A. We are talking about group A. It is always worthwhile that we have a video consultation. Basically, if you read the whole data set, is the language and the tenor always is that two things. One, that whatever you're doing on telemedicine, as long as you're doing with a good intention, probably will be accepted. You are doing it with good intention, right? Now, they always say that the physician-patient interaction is far more in a video book, because one, you can see him. If he's, for example, if he's very dehydrated and he's tired, obviously you might say, okay, see, you look very tired and dehydrated and dried up and all that. Before I give you an SGLT inhibitor, I'd want to know how is your blood pressure, or I don't think it is safe for you to continue it, right? And the other day we were talking to somebody who said that they saw a patient and found that the patient was actually breathing like the ketonic breathing and cyanotic breathing. So you can make a diagnosis, or maybe there's a diabetic ketosis. So the thrust is always that it's better to have a video consultation before you change major medicine, whether it's diabetes, hypertension, even if the patient doesn't follow up. I would say that we should insist on a video consultation, because audio, we have burnt our fingers many times. Okay, we had patient who had called up and said that I had a patient who said that, sir, you had told me to let you know the TSH report, and TSH is 7.2. So I said, do you have any other problem? No, you don't have a problem. You just told me to let you know the TSH result. So reflexly, I was almost at the brink of starting him on a small dose of thyroxine, right? TSH. But I said, no, I need to see your old prescription. So when he showed me the old prescription, it had amiodarone. Amiodarone. So amiodarone is a drug that increases TSH. There's no need to start him on thyroxine. So when I asked, he said with a good intention that, no, I've never taken a drug for thyroid and I have no thyroid problem. You just told me to repeat thyroxine, TSH test and let you know. So I think it is always worthwhile. Two things: that get the patient, put all his investigation and old records available in the chat box or screen it so that you have it in your side by the time you're consulting, so you don't go wrong. Drugs are not duplicated. And he might be taking some medicine from the cardiologist and might be taking something from the diabetologist, something from the nephrologist, and they might be overlapping. And the patient might not even realize and tell you that, oh, this medicine I was already taking. Nobody told me to stop it. And you give me this. So he might be on 2 ACE inhibitors, 2 calcium antagonists and stuff like that. So I think it is always better that ask the patient, now, give me the entire list of medicines that you are taking. Let me see the entire investigation list that is available to you. And it is probably better that I see you so that one-to-one I can know how you are.
Sir, this is rather a concern from Guru Prasad. Sir, it is a rule that charges should be the same as physical consultation in case of telemedicine.
Yeah.
But can't we charge little more? As this, we have to pay for the platform and all. So, is this like should we? And also, the patients will not spend more in transport also. So, is it possible, or what's your opinion? And this is a concern, rather.
No, see, this is not an opinion, but the guidelines say that it should be at par with your standard consultation fees. So I think that is an area which is gray. So I think legally we should only charge whatever fees is we are charging for a standard consultation, because government has said that telemedicine consultation you should charge the same thing. I agree that the vendor might you can always say that the vendor can collect the money from the per patient fees from the patient is paying. So if your fees is 500 rupees, the patient can always pay 550 rupees. The 50 rupees goes to the vendor who is providing all the services, and still your consultation remains the same.
Sir, there is one more question by Dr. Kumar Patil. Patient was seen by a consultant A, and later on he want to change the consultant. Is it okay if we do tele consultations?
As of now, no. As of now, the answer is no, because you don't know the clinical ability or the acumen of consultant A. Consultant A might have made a totally wrong diagnosis. So right now, it is not possible that you take a consultant A's view that is and follow a patient. If you had not seen the patient yourself, it still constitutes a new patient for you, and you have to follow the guidelines. That is very clear to me.
And a question related to COVID, sir, a hot topic again. How do you identify COVID-induced myocarditis?
Okay. I think that is more of a cardiology issue. See, the problem is COVID myocarditis is not very common. Understand that COVID itself, 95% of patients of COVID are not going to be symptomatic at all. And those who fall ill, they can either come with an first group may come to the cardiology with just an elevated troponin, and they might be actually fine. Their ECGs are okay, they have nothing else but an elevated troponin, which is part of the inflammatory reaction that is going in. So slightly elevated troponin over time, which comes down, does not mean that the patient has acute coronary syndrome or a myocarditis. That is point number one. Second, a group of patients present exactly like an acute coronary syndrome. They can be either a thrombotic occlusion of the coronaries or significant ECG change with troponin rise, or they can be something like a Takotsubo syndrome, whereby it is a stress cardiomyopathy kind of feature. Third, presence with a gross cardiac failure or an incessant arrhythmia, the typical of myocarditis. Their incidence is very low. In fact, the first few weeks of COVID, we said that in the typical myocarditis, whatever biopsy specimen we saw, we never found a virus in the myocardium. So probably myocardium gets affected by a part of generalized inflammation, something like the cytokine storm we are talking about. So most patients with myocarditis are extremely sick. Either they are on ARDS on ventilators, or they have a multi-organ damage. So either they have multi-organ damage or they are on ventilator for an ARDS. And when you do an echo, you find typical of LV dysfunction. The typical of LV dysfunctions, if you ask the question, is when the myocardial cavity is not enlarged. I repeat, is not enlarged, but the myocardial thickness is preserved or slightly more. But the LV function is extremely poor. So the left ventricle is not contracting well, but not dilated, because it does not have enough time to dilate. And the muscle mass thickness is slightly normal or slightly more, not thinned down. That is typical of COVID myocarditis. COVID myocarditis treatment should be like any other myocarditis. Support, hemodynamic support. If there is congestion, decongest, and of course oxygen and ventilator. Does steroid have a role? There is no conclusive evidence that there is a role for steroid in COVID myocarditis. Steroid can be indicated in COVID, provided there is another indication, like an severe ARDS or a pressure-resistant hypotension, or maybe COPD or whatever.
Sir, I think we have done with the question answer session. And I thank you very much for an elaborate question and answer session. You have explained it so clearly how to manage the COVID patients and what are the guidelines of the telemedicine. It was very clear. Hope our audiences are very clear about the talk. Now I would request Vasant to give the vote of thanks.
Uh, Thank you so much, sir, for a wonderful session. And it is always feel thrilled about to listen you, sir. I think same medical fraternity across the India is thinking about it. The questions has been clarified very well, sir. From on behalf of Ajanta, sir, Ajanta is a top player in cardiology market and committed to launch a new products, first time India products. Saying thank you to you also and the medical fraternity who join across the India. I also give the occasion to say thank you to Dr. Veena Venkatesh also, who nicely delivered the questions towards you, sir. And also, I give a thanks to my field who gathered a medical fraternity from across India. Thank you so much, sir. Thank you so much, and have a nice day,
All
sir.
of you, the entire team of Ajanta, for organizing this so well. Thank you very, very much. And
Thank you very much, sir. Thank you. Thank you for your time.